Hello friends, this is Dr. Rajal Shah. Hope you are healthy and safe. Today I try to bring a second topic on a Dummies Guide series. My first topic was on prostate cancer and I have got very good reviews from you. So I am trying to make a second Dummies Guide to bladder cancer diagnosis. This is a very important topic in my experience. Evaluation of bladder and urinary tract specimens can be quite challenging unless you apply a methodical approach towards the evaluation of these specimens. So today I'm going to try to show you how you can utilize a very methodical approach towards evaluation of these specimens. So let us first try to understand the scope of this particular problem. Bladder cancer, it is estimated that it affects about 81,000 patients annually. 17,000 patients die from this disease. Bladder cancer has a long natural history of recurrence and progression, so that accounts for its very high prevalence. If you make a new diagnosis of bladder cancer, it is very likely that you are going to see that particular patient in surveillance, and you are going to encounter urine cytology and bladder biopsies on frequent basis. And in fact, it is now one of the most expensive cancer to treat. It is the fourth most common cancer in men. So it has a significant magnitude. So let's try to kind of develop a systematic approach. So first question that you should ask is that what type of biopsy I am dealing with. There are two types of specimens that are common. One is called biopsy, which has also been referred to as a cup biopsy. This type of procedure is typically intended to evaluate when you have a mucosal abnormality. And good news with this type of specimens is that you are going to have excellent cytological and architectural preservation, very few artifacts, but it is not optimal for the tumor staging purposes. The second very frequently encountered specimen is called transurethral resection, also known as TURBT or transurethral resection of bladder tumor. It is typically performed to evaluate tumor and done for staging purposes. The problem with this specimen is that you are going to encounter high degree of artifacts, tangential sectioning of the epithelium, tumor fragmentation, cautery or thermal artifacts. All of these are going to give you a lot of, I think, evaluation in terms of next steps of questions. So I think keep those artifacts in mind, and I think try to resolve them. My second question I always ask is that is biopsy within normal limits? So if we look at the normal histology of urothelium, the thickness can vary significantly depending on the bladder distension. It can be up to 7 cells thick. Typically, urothelium, which has also been in past referred to as a transitional epithelium, is composed of basal, intermediate, and superficial umbrella cells. Now these are typically cuboidal to polyhedral type of cells. Sometimes they can have a little bit columnar look to it. Umbrella cells or the superficial cells can undergo marked reactive changes. Here is the umbrella cells, and you can see that this particular layer is susceptible to significant reactive changes. It may mimic CIS if you are not careful. Typically, the helpful feature is very low nucleus to cytoplasmic ratio. Another very important artifact that commonly occurs within the urinary tract specimen is denudation. We often refer to denudation as a part of a CIS process, but keep in mind that denudation as an iatrogenic induced process is very, very common. Now, what are some of the common variations or kind of nuances that I think you need to be aware about One of the very important one is called von Brunn nest. These are rounded nest of urothelium which are placed typically within the lamina propria. When it undergoes cystic change, it is referred to as a cystitis cystica, and when it undergoes columnar metaplasia, which can be intestinal type or non-intestinal type, it is referred to as a cystitis glandularis. Now, both of these processes can undergo significant proliferation and can cause confusion with the neoplasm, and I will talk about some of these later on when I talk about the pseudotumors of urinary tract. So my next question is biopsy then abnormal or neoplastic? Typically, abnormal process within urinary tract specimens has three architecture: papillary, flat, or inverted. Inverted has also been referred to as an endophytic proliferation. So the next question to ask is that what is the architecture of this abnormal process that you are dealing with it? Next question is, have I excluded pseudotumors or mimics? And keep in mind that for all three architectural processes, you are going to have a pseudotumors or mimics. So we are going to answer for each of these architectural features that have I excluded the pseudotumors. How do these three questions you can construct more effectively? It is very, very important to know what is the previous history. Am I dealing with stones, history of catheterization or indwelling catheterization? Are there any chronic irritative processes? Has there been an issue with the neurogenic or inactive bladder? Is patient has a previous diagnosis of tumor? If yes, what type of treatment has been utilized for previous cancer? What did the cystoscopy show? Was there a lesion, mucosal abnormality, or papillary tumor? So all of these are very, very important questions to ask when you deal with these specimens. So as I told you, there are three major architectural patterns of urothelial lesions: papillary, flat, and endophytic. Now remember that for all these architectural patterns, you have non-invasive and invasive processes. So first we will talk about the papillary process, which is the most common pattern that you are going to encounter. Now, what is the definition of neoplastic papilla? So when you have a well-defined central fibrovascular core with or without branching, and it is lined by normal or thickened urothelium. Here are the two examples for that. That is the definition of papillary urothelial neoplasm. So if you think that your papillary process has a well-defined central fibrovascular core which may be branching or may not be branching, that is pretty much characteristic that you are dealing with a neoplastic papillary process. And this papilla can be seen in a finger-like manner, or when they are cut tangentially, they give you this type of appearance, more cut appearance of the fingers. So here are these four common papillary neoplastic processes based on 2016 WHO classification: papilloma, which has a normal urothelial lining with no architectural or cytological atypia. You can have a hyperplastic but pretty much bland looking cytological process, which is referred to as a papillary urothelial neoplasm of low malignant potential. And then you could be dealing with a low grade papillary urothelial carcinoma and a high grade process. And we will talk about how to distinguish low from high grade in a subsequent sections. So what are the common mimics of papillary neoplasm? There are two very important ones to keep in mind: papillary polypoid cystitis, which typically results due to various inflammatory insults such as fistula, indwelling catheter, any chronic irritative processes. And then the second one is nephrogenic adenoma, also referred to as a nephrogenic metaplasia. It is typically seen in the setting of neurogenic bladder and variety of other chronic irritative conditions, inflammation, long-standing catheterization, history of tumors, all of these different things can give to these two pseudotumors. So now let's try to understand how you can distinguish true neoplasm from these pseudotumors. So here is a side-by-side comparison of all these three papillary processes for you. So papillary urothelial neoplasm is characterized, as I discussed, well-defined, slender, and frequently branching fibrovascular course, and then the papilla can be lined by normal or abnormal multi-layered epithelium. So that is the characteristic of a papillary neoplasm. Polypoid cystitis in comparison is characterized by lack of slender or branching fibrovascular course. The papilla are typically going to look very edematous or sometimes fibrous with broad base, lack of any delicate fibrovascular course, and inflammatory background is also characteristic. Here is another example where you can see clearly distinct papilla, but they are very edematous without any central fibrovascular core, and pay attention to the background, which is typically will give you important clues. Nephrogenic adenoma again also lacks slender or branching fibrovascular cores. Papilla are typically lined by single layer of cuboidal epithelium. That is a very important feature for nephrogenic adenoma. In comparison, papillary neoplasm typically have a multi-layered epithelium, and of course about slender fibrovascular core is also an important point. And keep in mind that nephrogenic adenoma typically presents with both papillary and tubulopapillary components. So tubular component is pretty much most of the time you are going to find it. And then if you have doubt, PAC-set can be a very useful marker for your confirmation. Here is a component of tubular portion of nephrogenic adenoma characterized by home nailing, and then there is a collar of hyalinized basement membrane. Inflammation is also very common, but this is one of the very versatile lesion which can give you significant heartburn if you are not aware about this condition, and I will try to cover this as a separate entity in one of my videos. So next is a flat growth. Again, it can be non-invasive or it can be invasive. So neoplastic flat lesions are classified based on the degree of cytological and architectural atypia, and the two common lesions within this spectrums are dysplasia and CIS. When you have mild and moderate type of cytological atypia or an architectural atypia, they are defined as a dysplasia, and severe dysplasia in urinary tract specimen is considered equivalent to flat carcinoma in situ. So do not use word severe dysplasia like it is prevalent in some other organ systems. For urinary tract system, severe dysplasia is equivalent to flat carcinoma in situ. So let us try to understand flat carcinoma in situ, which is one of the most important flat process that you do not want to miss in your practice. So this is a high-grade non-invasive process. Very important rule to keep in mind that you do not need full thickness epithelial atypia to make a diagnosis of flat carcinoma in situ. There are several major and minor features that you can apply. Major features includes loss of polarity with significant nuclear crowding, significant nuclear enlargement where the enlarged nuclei are 4 to 5 times of underlying stromal cells. We will see some examples. Nuclei are typically have a hyperchromatic lumpy chromatin pattern and irregular nuclear membranes. Here are some of the minor features, and one of my favorite one that I like to see is a cellular discohesion, which is very common with flat carcinoma in situ. And also this process often have a neoangiogenesis at the base, and that what gives a characteristic strawberry patch or erythematous patch type of appearance, flat appearance in the cystoscopy, which is a very characteristic of flat carcinoma in situ. And when they see, urologists see that, that's what they try to biopsy. So here are some of the common morphological presentation of CIS. You can see here this flat process has a significant loss of polarity. There is significant variation in size and shape of the nuclei. There are many atypical mitosis high up in the epithelium. So I think this is clearly a high grade process. Keep in mind that we talked about that you do not need a full thickness cytological atypia. So this is an undermining process of flat carcinoma in situ where you have significantly atypical or malignant looking cells primarily in the lower part of epithelium with some normal maturation going on. And then flat carcinoma in situ can spread within underlying von Brun's nest and cystitis cystica. At that time, it is very important not to confuse it as an invasive process. You can see here that this nest still have a pretty round, regular, uniform appearance. So as we discussed, I think there are various morphological subtypes that have been proposed. This is a very famous illustration by Dr. Jesse McKinney and colleagues, in which they divide flat carcinoma in situ into 6 different morphological subtypes: large cell pleomorphic, large cell non-pleomorphic, small cell, clinging or denuding one, cancerization, pagetoid, and cancerization undermining. I showed you this particular example. Now let's see one of these 2 other common manifestations. So denuding CIS is a very, very important one to recognize. Flat carcinoma in situ by definition has a loss of cohesion, so there is a lot of exfoliation of cells going on, and sometimes all you may see is like pretty much ulcerated or denuded urothelial mucosa. So in this scenario, try to look at to see whether you have this lot of neoangiogenesis, and then carefully examine multiple levels to document the presence of high grade atypical cells. You may have even few cells like this. That is enough to make a diagnosis of denuding flat carcinoma in situ. Another very important one is pagetoid flat carcinoma in situ, in which large atypical cells with abundant cytoplasm, they spread like superficial spreading malignant melanoma type of pattern. And in this particular pattern, CK20 can often highlight you these abnormal pagetoid cells. Here is an example of a urothelial dysplasia. So in this one, you would appreciate that there is a significant cytological atypia. There is mild to moderate architectural and cytological atypia, but this atypia clearly lacks that distinct high-grade character to it. So this is referred to as a urothelial dysplasia, which is a pre-neoplastic process, falls short of diagnosis of flat carcinoma in situ. Very important to keep in mind that this particular process can sometimes be quite hard to distinguish from reactive processes. And I think the problem with this particular entity is that it can be quite subjective with poor inter-observer reproducibility. So I try to make this diagnosis in de novo setting in a very, very strict manner. Usually the diagnosis is made more readily when you have a previous history of urothelial carcinoma. Another important point to keep in mind that flat processes may not always be flat. There could be some undulations or papillations going on, but look at that this papillation lack the characteristic neoplastic process of a delicate fibrovascular course. So these are pseudopapilla to some extent, but the lining epithelium is quite hyperplastic without any significant cytological atypia. So this type of process now in a newer classification has been referred to as a urothelial proliferation of uncertain malignant potential, or U-pump. Previously it used to be classified as a urothelial hyperplasia. And here is another example where you have relatively more flat process. So if I see this type of very hyperplastic urothelium without any cytological atypia, I commonly refer to as a U-pump. But if there is a significant cytological atypia, I typically characterize that as a neoplastic, more frank neoplastic process. So let's see some facts about this interesting phenomenon. This is typically seen in patients with history of prior carcinoma or adjacent to papillary lesions. So most of the time it is likely going to be a so-called shoulder lesion or lateral extension of a papillary neoplasm. If there is no previous history of neoplasm, then it may be seen as a de novo finding, and in this setting the clinical relevance is somewhat unknown. But it is often considered to be a pre-neoplastic process because you can see high incidence of chromosome 9 deletions and lesser but significant FGFR3 abnormality. So to some extent these are precursors to low-grade urothelial neoplasms. It is important not to confuse it with a papillary urothelial neoplasm of low malignant potential. So its overuse and misuse must be avoided. And as I said, the previous terminology for this entity is urothelial hyperplasia. So what are the common benign mimics of flat neoplasms? Here are the three: inflammatory reactive atypia. So typically you will have a history or background in the setting of inflammation, impacted stones, instrumentation or previous therapy. Then you can have a clear-cut history of therapy in which you can find variety of type of cytological processes. And then very rarely nephrogenic adenoma can purely present as a flat process, but it is a very, very unusual pure presentation. So it is unlikely to be commonly encountered as an isolated process. So here are the common therapies that have been utilized in bladder cancer. Now cyclophosphamide is pretty much not utilized. It is of more historical significance. BCG is a very commonly utilized treatment for high-grade urothelial carcinoma and flat carcinoma in situ. Typically you see granulometastasis response and sometimes atypical urothelium. Mitomycin is also commonly utilized in particularly setting of low-grade urothelial tumors. It is believed that this treatment can reduce tumor recurrence and prolong survival, and it can induce significant atypia in umbrella cells. Cyclophosphamide can produce cytological atypia severe enough which can mimic CIS, has also been referred to as an hemorrhagic cystitis. It is a kind of a chemotherapy to some extent, and then radiation is also one of the very commonly utilized treatment, particularly for prostate cancer or sometime in the setting of bladder cancer. So here are these mimics and CIS side-by-side comparison. In the reactive atypia, typically the polarity or architecture is in general maintained. You can see that these cells in general have uniform polarity. Nuclei are enlarged, but they are typically more uniformly enlarged. They have a vesicular chromatin with a single prominent juicy nucleoli. Nucleoli typically has an angry look to it, eosinophilic and prominent type. And most important is to also appreciate the inflammatory background within the biopsy. And that is very, very important. When you have a very significant intense inflammation, you should have a higher threshold to classify it as a flat neoplastic process. Therapy-induced atypia, also polarity is usually preserved. You can have enlarged pleomorphic nuclei, but important thing is that the atypia is degenerative type with degenerative smudgy chromatin within the nuclei as seen here. Frequent cytoplasmic vacuolization can be seen. And then very important again, which I will show you in the later slide, is that it is very, very important to appreciate the stromal background. That can give you very important clues for the diagnosis. And here is another example of a classic CIS. I have some high power views. Here is the reactive atypia high power view where you can see more angry looking nuclei. And here is the therapy atypia, again smudgy chromatin pattern with degenerative chromatin. And again look at this hemorrhagic background, which is more characteristic of previous therapy. And in CIS typically you have loss of polarity, Nuclei are very hyperchromatic, 4 to 5 times than the underlying stromal cells. Nuclear crowding, high atypical mitosis can be seen, and then you can have also neovascularization. So here are some examples. So the way you carefully analyze this epithelium, it is also very, very important to evaluate carefully the stroma or the background of the specimen. When you see very congested stroma showing you hemorrhage and fibrin thrombi, that is one feature that is very typical of therapy. Here is another example where you see thrombi with free hemorrhage. In this type of setting, you can also have epithelial proliferation, which has been referred to as a pseudocarcinomatous epithelial proliferation, because it can potentially mimic as a neoplasm. And then in this particular example, you have a myofibroblastic type cellular proliferation. Sometimes stroma can have a very reactive atypical stromal cells. So when you see this type of stromal features, think about reactive process typically associated with post-therapy. Sometimes you may not even elicit any history of previous treatment. They can still be typically associated with a vascular compromise and other reactive type of processes. So immunohistochemistry of all the three processes, perhaps the most widely utilized and perhaps most useful in this particular setting. CK20, CD44, P53 and Ki67 are widely utilized, particularly for these flat lesions. But a word of caution is that you should use these markers judiciously. Morphology remains the gold standard. So if you see morphology which is otherwise typical of a particular process, do not use these markers because sometimes they can confuse you. So two widely utilized markers are shown here, P53. If you see aberrant diffuse P53 staining like this example, that is pretty specific for CIS, but it is not sensitive for CIS. So a lack of staining, diffuse staining does not necessarily rule out the process. CK20 typically shows superficial umbrella cell staining pattern in normal and reactive conditions, while CIS and dysplasia are characterized by full thickness staining abnormality. Very important to keep in mind that Ki67 can be high in reactive conditions, and so particularly when you have a very inflammatory biopsy, I do not use this particular marker because it sometimes can give you false positive reading. And another important point to keep in mind is that these markers should not be utilized to distinguish between dysplasia from CIS, that is purely or morphological. The next important process is inverted growth pattern. Again, it can be non-invasive and invasive. And this particular growth pattern is the one which causes most difficulty to distinguish from invasive process. So I will emphasize on invasion question, this particular process as well. So here are some neoplastic inverted processes. You can have non-invasive, benign inverted urothelial papilloma. So this would also fall into so-called pseudotumors or tumor-like condition, because this is a completely benign condition which should be distinguished from inverted urothelial neoplasm of low malignant potential. Inverted low-grade urothelial carcinoma. You can have inverted high-grade urothelial carcinoma which can be non-invasive or invasive. And then this more recently described large nested urothelial carcinoma can also cause significant confusion within the spectrum of endophytic tumors. Here are three important benign mimics of inverted neoplasms to keep in mind: proliferative von Brun's nest, prominent cystitis cystica, and then inverted papilloma. This is kind of a neoplasm, but I have included this in a benign mimics because this to some extent is really a benign process. So here is a side-by-side comparison of these three processes, endophytic processes. All three are non-invasive processes. So let's try to understand them. Cystitis cystica is a reactive condition The mucosa is typically flat. It is characterized by variable size and place nest with prominent cystic changes. The epithelium is typically not very proliferative in appearance. And at high power, you are going to see benign cytology. And inflammatory and edematous type of background is very common, and that is again very, very important to carefully look at the background to come to a right diagnosis. I typically do not use markers in this type of differentials. So this is more of a morphological and clinical dilemma to resolve. Inverted papilloma has typically an attenuated mucosa on the surface. So the process is typically very endophytic. It is characterized by proliferation of this nest and trabecula, which are almost seen in a tight jigsaw puzzle pattern. That's a very important. It almost fits like a pieces of puzzle with a very limited space in between. So they are very orderly, very tight and compact. Nests are typically not going to look very rounded and proliferative. You can see spindle cells at the center of the nest. There is also frequently prominent peripheral palisading that you can see in the outer layer. And again, this is benign cytology. So this is very characteristic of inverted papilloma. We will also talk about later on the epithelium and stromal base. Both of these processes are characterized by relatively very uniform base. Non-invasive low-grade urothelial carcinoma or non-invasive papillary urothelial neoplasm of low malignant potential with prominent endophytic growth typically has a frequent exophytic component, so they are very rarely going to be purely endophytic. Proliferating nests are typically rounder, bulbous, and very disorderly. You are going to see a lot of space between them. They are more haphazardly placed. They lack prominent spindle cells and peripheral palisading. So those features, like compared to inverted papilloma, can be very helpful to appreciate. And usually you have some degree of atypical cytology depending on the type of process that you are dealing with. So my next important question is, now am I dealing with a low or high grade process? And why this distinction is important? Because typically for high grade processes, urologists are going to give BCG as an additional treatment. So let's try to understand where this current classification comes from. So the original classification of non-invasive papillary urothelial neoplasms was typically divided into 3-tier system in addition to papilloma, which is a benign process. From that 3-tier system, now we have a 2-tier system. The tumors are divided into low grade and high grade processes. Majority of grade 1 goes into pun lump category. Some of them would fall into low grade. But an important point to keep in mind that previously we had a luxury to put somewhat borderline tumors into grade 2 category, and that's why it became a kind of, to some extent, a wastebasket particular category. So if we look at literature of what happens to grade 2 tumors, it is shown that many of these grade 2 tumors in fact have a higher rate of recurrence and progression. So many of those so-called old WHO grade 2 tumors, if you pay careful attention, they would perhaps fall more into high grade category. So we have a more high grade representation in the newer classification system, and I will talk a little bit about this in next slide. So again, your grading is going to be based on the degree of architectural and cytological atypia. You are going to focus on all those characteristics: polarity of nuclei, nuclear size, shape, outlines, chromatin structure, atypical mitosis. In general, low grade has a very minimal or mild abnormality, while high grade processes typically have a more low power recognizable atypia that you can appreciate. Sometimes you may have a uniform nuclei, but numerous atypical mitosis can be seen, nuclear crowding can be seen, hyperchromasia. So all of those features now more fall into high grade particular category. So it is now consensus that if you have a high grade component that accounts for 10% of the, more than 10% of the tumor, pretty much everybody consider that as a high grade urothelial carcinoma for classification purposes. But if the high grade component is less than 10%, there is no clearly consensus. I use particularly in that setting diagnosis of predominantly low with focal high grade urothelial carcinoma. Now, most of the time urologists are given to give BCG in this setting, but some studies have shown that when you have a very minor, typically if less than 5% of high grade component, many times these tumors still behave more like low grade tumors. It is very important to keep in mind that if you are dealing with upper urinary tract tumors, you should be very conservative, because remember, in upper tract tumors, if you make a diagnosis of neoplasm, most of the time you are going to end up getting an nephroureterectomy specimen as a part of treatment. So it is very important to be conservative in those type of specimens. You really want to see more recognizable features of tumor and particular grade. So here is a side-by-side analogy of all these different architectural variations of tumors in terms of degree of atypia. So if you have no atypia, papillary counterpart will be papilloma, flat counter would be normal, endophytic would be inverted papilloma. If your atypia is minimal or absent, papillary counterpart would be pun lump, flat counterpart would be U pump, and then endophytic counterpart will be inverted pun lump. If you have a distinct mild to moderate cytological atypia, then it is low grade papillary urothelial carcinoma. Flat equivalent would be dysplasia, and then endophytic counterpart would be inverted low grade urothelial carcinoma. And when you have at least focally severe atypia, majority of experts would classify that as a high grade urothelial carcinoma, and equivalent in the flat process would be CIS, and equivalent in an endophytic setting will be inverted high grade urothelial carcinoma. My next very important question is that, am I dealing with invasive process? Have I excluded tangential sectioning, artifacts, tumor fragmentation, particularly when I am dealing with a TURBT type of specimens? So there are 4 features when present that can be very helpful to suggest that you are dealing with an invasive process. Number 1 very, very helpful feature is when you see stromal retraction and paradoxical maturation. Stromal retraction is where you have nest which is separated with a space from the stroma. This is one of the most common feature of invasion. In paradoxical maturation, the overlying nest have a much less cytoplasm compared to much broader cytoplasm in the invasive front. This is very helpful, particularly when you are dealing with a very small focus of invasion. If you have an obvious desmoplastic stroma like this example, that is pretty characteristic of invasion. Sometime in TURBT specimens, you are going to deal with a lot of artifacts and thermal artifacts in particularly. But in this particular example, you can see that this particular, even though there are artifacts, it is very complex in architecture. At the periphery of this tumor, there is a lot of irregularity. You can see a lot of single cells, some with some retraction artifacts. So there is some degree of minimal invasion that is seen in this particular example. And when you have a myxoid stroma with small irregular nest, that is also considered to be a useful feature of lamina propria invasion. So if invasion is obvious, usually you don't have to worry about applying these features. But when you are dealing with a small foci, particularly you are trying to rule out tangential sectioning, tumor fragmentations, artifacts, these are the features to look for. In endophytic tumors, looking at the epithelial and stromal interface is an extremely critical. I have talked about this in a variant histological differentiation in bladder cancer topic quite a bit, so I will keep it to the point. Benign proliferative von Brunn nest processes are typically characterized by very crowded, very uniform, orderly interface where you can almost draw a line, while nested urothelial carcinoma, which at low and high magnification nest are going to look essentially like proliferative von Brunn's nest from cytological point of view. But if you look at the interface, it is very disorderly. You have a lot of confluence, disorganized growth. You cannot make a clear-cut boundary between the proliferation and underlying stroma. So when you see this type of feature in biopsy, always think about some of these important endophytic processes such as nested urothelial carcinoma. Here is a side-by-side comparison of inverted papilloma, and then here you have invasive high-grade urothelial carcinoma with inverted papilloma-like growth pattern, but then you have a very disorderly epithelial and stromal interface. You can also see that the stroma looks pretty reactive, and when you look at high power, you can see that there are small irregular infiltrating nests with myxoid stroma, jigsaw kind of haphazard growth. So these are the features that would help you to distinguish an invasion from a so-called endophytic process, which itself can confuse you with invasion. And again, as I said, that when you are dealing with endophytic setting, pay careful attention to epithelial and stromal interface. Large nested urothelial carcinoma is included within the spectrum of nested urothelial carcinoma. Again, I have talked about this in histologic variants of urothelial carcinoma, but this can be distinguished from non-invasive urothelial carcinoma showing prominent inverted growth pattern by any of these three features: muscularis propria invasion, irregularly infiltrating nests, and stromal reaction. Here is one example where you see that at low power, this is a very prominent endophytic growth. You do see a little bit of exophytic papillary component, but this one at high power also looks relatively monotonous. So your confusion is that could this be a non-invasive low-grade urothelial carcinoma showing endophytic features? Then when we look at the epithelial and stromal interface, you can start seeing there is many irregular nests sitting deep within the muscle and stroma. There is also inflammatory and desmoplastic type of response that you can appreciate. So even though these have a blind cytology, based on these features, you can make a diagnosis of large nested urothelial carcinoma. My next important question is that if there is invasion, how deep is the invasion? Is this in lamina propria or muscularis propria? And if there is no invasion in the biopsy, do I have a normal muscularis propria? Again, that's important question to ask, because that even though you may not see invasion, it is very important to document this particular feature in your report for the proper evaluation of the representativeness of biopsy. So I think let's try to understand that urothelial carcinomas are typically divided into superficial tumors and muscle invasive tumors. Superficial tumors includes non-invasive tumors, lamina propria invasive tumors, which has also been referred to as a PT1 tumors, and then in situ flat carcinoma tumors like CIS, which is also referred to as a PTIS, while this one referred to as a non-invasive papillary urothelial carcinoma. Now, the problem with this type of lumping everything into superficial category is a problem, because if you look at the outcome, there is a quite variation within the outcome. Particularly PT1 category is quite heterogeneous. So in that particular setting, depending on the level of invasion, depending on the amount of invasion, the outcome is going to be significantly different. So in this type of setting, understaging is also quite common. So now in the newer AJCC staging manual, it is clearly emphasized that wherever possible, you should try to substage T1 tumors into focal versus extensive disease. The muscle invasive disease is characterized as or classified as a T2 disease. And in the superficial disease, the goal is the organ preservation, while in muscle invasive disease, the goal is neoadjuvant chemotherapy followed by cystectomy. That is typical gold standard and the goal. and majority of these tumors progress with higher metastasis. So that's why I think by explaining you this biology of bladder cancers, you can now understand that in biopsy specimens and resection specimens, it is very, very critical to document how deep is your invasion and how much is the invasion. That is going to be a very important prognostic parameter. So let us try to understand the normal histology of urinary bladder wall. Urinary bladder wall has a mucosa, then a layer of so-called lamina propria. Lamina propria is composed of thin connective tissue, vascular connective tissue, and within this lamina propria, you often can find thin, wispy, discontinuous, pointed muscle fibers like these, which are typically associated with thick blood vessels, and they are referred to as a muscularis mucosae. Underneath lamina propria, you have muscularis propria layer, which is divided into inner and outer. Muscularis propria is also referred to as a detrusor muscle. They are characterized by thick rounded bundles of muscle fibers with gapping spaces in between. So distinction of this muscularis mucosae from propria is very critical from staging point of view, and I will try to talk more about that in next slide. Here is a nice example of muscularis mucosa within the lamina propria. Some facts to remember about muscularis mucosae is that as a landmark, it can be absent in up to 15 to 20% of biopsy specimens. So even though sometimes you may carefully look for it, you may not find it. And in that setting, this thin connective tissue and thick blood vessels could be more important landmarks. It is typically absent in ureter and pelvic calyceal mucosa. It is also thin or absent in trigone and bladder neck. So in trigone and bladder neck, you are going to see muscularis propria immediately opposed to mucosa, and you may not have any lamina propria that you can easily identify. But infrequently, it can also be hypertrophic like this particular example, and in that setting, it is important not to confuse it with a muscularis propria. Look at that, this one still has a pointed, discontinuous muscle fibers. They are thick, but they lack that rounded character of muscularis propria. And then another very important variation to keep in mind that if you are dealing with diverticulum type of specimen, it has a hypertrophic muscularis mucosae and typically lack muscularis propria. So keep these facts in your mind when you deal with bladder and urinary tract specimens. Here is side-by-side comparison of muscularis mucosae versus muscle invasion. Muscularis mucosae invasion would be considered T1 or lamina propria invasion, and this is what I would consider as an extensive disease. I always try to give some quantitative estimation of whether am I dealing with a focal versus extensive lamina propria invasion. Note all these pointed, thin, wispy muscle fibers of muscularis mucosae. In comparison, here you have tumor that is encircling these round, thick bundles of muscularis propria. Sometimes this muscularis propria may get splitted by the tumor, and in that setting it may get confused with muscularis mucosae. But it is very unusual to see a continuous layer of muscle like this in a row. It is more likely you are dealing with splitted muscularis propria. Next important question I ask is there any lymphovascular invasion? Lymphovascular invasion is an important prognostic parameter in invasive tumors, and your typical differential diagnosis is stromal reaction. So how do you distinguish them? Sometimes if you have a very fragmented tumor, your knife can also carry tumor within these spaces. So the way you recognize true lymphovascular invasion from artifacts is that the tumor cells should look well preserved. It typically confirms the shape of the blood vessels. You frequently find endothelial attachment. And I think this process typically you see more in the deeper aspect of the specimens or biopsies. If you see in a very superficial area, likely you are dealing with an invasive urothelial carcinoma showing you stromal retraction. So I try to stay very conservative in superficial areas. You don't want to overcall this feature as well. So a conservative and methodical approach is very important. My last question is that is there any variant histological or a non-urothelial differentiation am I dealing with? And for that I would refer you to a dedicated video on this particular topic that I have posted some time back. So please watch that along with this video. And then I think here are some TURBT handling guidelines. Sometimes these samples can be very bulky. So if you can sample all material within 8 cassettes, try to put everything. If it is very bulky tumor, sample 10 to 12 blocks if extensive. Sample all if the diagnosis and stage remains unclear. And most importantly, if your cystoscopy and clinical picture do not correlate with what you are seeing, then often making deeper cuts is also very helpful practice. So with that, I thank you very much for your attention. I hope you enjoyed this simplified approach. If you like this presentation, please share with your other friends, colleagues, subscribe to my channel and like the video. Thank you.